Looking back with hindsight, this was really the beginning of a very important development that has taken place since in relation to trying to define the earliest phases or stages of Parkinson's disease. We were all convinced, everybody was, that there is a phase of Parkinson's where symptoms have not become apparent, at least not the defining clinical features of Parkinson's disease, but the disease is still already ongoing. The eventual methodology was just to look at what we know from prospective studies on risk factors for Parkinson's disease and risk markers and how they behave longitudinally when they are present in somebody who is essentially healthy. And then this algorithm was developed to calculate risk scores based on certain assumptions, the age-specific prevalence of Parkinson's disease, the arbitrary decision to say the prodromal period lasts for 10 years, and then calculating the prior probability of being in that phase from epidemiological data, and then adding what is called the likelihood ratios for certain markers and risk factors as they were apparent in literature, meaning prospective studies, at least two, or meta-analyses. So these criteria really have a very solid base in terms of data and evidence. The group was aiming for a threshold of at least 80% accuracy. Why this paper resonates with me in particular is when I came home to my department and I reported to my close colleague and collegial friend Klaus Seppi on the task force work, he looked at me and said, "I can't imagine this will work, this kind of algorithm. I think it's a nice intellectual exercise, but I don't think it will work." So we set out testing it. We happened to have a population-based cohort of people aged above 50, which had been studied for years already with regular sequential in-person exams at 5-yearly intervals. So we could test sensitivity and specificity and positive predictive value of these criteria, more or less immediately after they had been published. And my skeptical colleague was truly amazed because it did work at the 5-year intervals. We had a positive predictive value of around 60%, and we had sensitivities of 40 and very high specificity. And we were able to do this again at 10 years, and the positive predictive value increased to 77% of the criteria. So in other words, they worked. Now that everyone is keen on getting biomarker-based definitions for disease, this has, of course, been a very timely effort and something that has been, I should say, groundbreaking in the concept, because it was already long before the current synuclein-based biomarkers became known and available. It was the same kind of thinking that we need to find ways to, in a scientifically sound fashion, try and define people who are at increased risk. We have a problem that we've been better at defining the earliest stages of Parkinson's disease than we have been at finding ways to prevent Parkinson's disease or to slow Parkinson's disease down. There is no simple answer to how do you translate risk algorithms for Parkinson's disease. So it's an individual conversation telling people you have an increased risk, to explain what that means. Importantly, it doesn't mean you will get the disease. Usually the chance of not getting it is bigger than of getting it. I think it's important to tell people situations where we all don't know what's ahead of us. And this is one of these examples.